ان انا كذا حاله، لكن انا نظرا للمشاكل اللي كانت حصلت اضطريت انقل على كمبيوتر ثاني. الكمبيوتر الثاني ما فيش غير حاله واحده بس اللي هتشتغل.
مقبوله منك يا دكتور محمد، اكيد زي الفل.
الله. وحاله طبعا انا كنت عامل، انا دي حاله على، انا عملت الحاله دي في 2016 حقيقه. he was 40 years gentleman, diabetic, hypertensive, very strong family history. He has a normal renal function. He came
شير
to us.
سكرين.
واضح؟
لا
واضحه يا باشا، اتفضل.
الصوره واضحه بتاعت الانجيو؟
ايوه واضحه.
طيب هو جالنا بنون ستيليفيشن مايوكاردال انفاركشن، وكان ده الانجيو بتاعه. الانجيو اللي ناقص the right coronary artery كان almost subtotally occluded the right coronary artery. I did the right coronary artery 2 days before this look trifurcated left main disease. If we look carefully in the picture, there is distal left main stenosis, and there is a critical stenosis of the ramus, critical stenosis and long lesion in the circumflex, and also there is a paraosteal long lesion in the ElNady. If you look here in this picture. And the question is, patient is refused to go to surgery, and we have to solve this problem. And it was a very complex case, but I tried to simplify the procedure to put 3 stents. But if you can agree with me that the ostium or the paraosteal part, the true bifurcation of the left main is not that involved in the lesion. If you look at the ostium of the ramus, you will see that it is free of any stenosis. If you look at the ostium of the circumflex and the paraosteal area, it is also free from any significant stenosis. Also the same for the ElNady. So I can change the procedure from a complex intervention just to make it simplified, and I go for stenting first the ramus. I put the stent just paraosteal to the trifurcation. I put 1 wire in the ElNady and the second wire in the ramus. And my plan is to go for the ramus first, circumflex second, and then finally to the ElNady and to the left main. This was my my strategy. And I need to finish the procedure with a provisional stenting, not with before to elective 2 stent technique or 3 stent technique. This is the first stent in the ramus. It was also drug-eluting stent, and this is a picture after putting the stent and also post dilatation with high pressure balloon. It looks perfect results in my opinion. The TM3 flows, there is no residual stenosis. It is also paraosteal, not reaching the true bifurcation. And I changed it to the circumflex. I put long stent to the distal circumflex and added another short stent to the proximal part of the circumflex, also not reaching the ostium of the circumflex. My feeling is there's no significant disease in the ostium of the circumflex. And it was 2016. I don't have an IVUS at that time. We have IVUS now in my center. And after that, I moved to the ElNady. I put the mid ElNady, long stent in the mid ElNady, and this was the results in the circumflex and the ramus. It looks, for my opinion, it looks very good results. And this is a picture to put a stent, provisionally stenting, just to put the wire in the ElNady, and I fixed the mid segment of the ElNady, and I put a stent from the ostium of the left main till the overlap with the stent in the proximal ElNady. This was 4 millimeter drug-eluting stent. I deployed the stent followed by post dilatation was 4.5 millimeter balloon, and this was the final results of this case. It looks, for me, it looks very acceptable results, and I changed the procedure from a very complex procedure just a provisional stenting. I mean, you can handle for the first look a very complex procedure to the simplified procedure, and this was the final results in this case. and this is the only case that it moves in today. Thank you very much.
It is very, very nice and very simple, Dr.
Yes.
Mohamed. I'm sure I have seen with you much more complex, but
Yes.
العبرة بالاوتكم. انت عندك هنا you had LED, you had left main, you had Remus as big as the CX or even as the LED, and you finished with having all of the three arteries. The only question اللي نسأله عليه ده مثلا هل السيركمفلكس ده كان محتاج تشوفه in other views عشان تتاكد ان هو هل هو مثلا بينشد اور نوت، وهل كان محتاج مثلا لو هتعمل له كيسنج وزي عملت له هنا الكيسنج السيكوينشال يتعملوا بقى مع ال دي ولا تعملوا مع الريمس ولا تعمل مع الاثنين واحد، يعني كل اثنين لوحديهم، مش بنعمل دلوقتي اللي هو 3 بلونز ات سيم تايم. فبس السؤال اللي بسالك عنه.
نعم. هو حقيقة الرايت coronary of this patient with a large vessel. It was a dominant right actually.
Okay.
I fixed it very well, and my procedure is if I have a TIMI3 flow and no pinching in the ostium, not to do even kissing, just to fix the left main LED, and you have a good flow in the ramus. And if you have some pinch in the circumference, I can leave it. You know, Dr. Ahmed, in the most of the time, if you have some pinching on especially with the stents, the left main, if you do fraction flow reserve, FFR, you will see it is not that reduced, not much, and most of the time you see it very well. And
يعني نسألك السؤال بطريقة تانية، امتى في السيركمفلكس ده كنت هتحتاج تشتغل عليه هو كمان؟ خليني اسألك تبقى ايه حصل اللي حصل؟
Stop totally occluded if it's 9% stenosis.
طبعا لو عندك FFR وعملته وطلع ان هو اسكيميا، لو احنا عندنا يعني الحاجة الثانية بقى كلينيكالي.
Yes, I will do kissing in this case. One balloon in the LED and one balloon in circumflex.
تمام.
This is my approach.
وهتobserve الOM.
وobserve الريمس. الريمس case. If I have something in the remus, I can do also with remus with the LED.
طيب هل حد من البانل يحبوا يعلق برضو يا جماعه؟ دكتور سليم، دكتور كريم.
شكرا دكتور سطيحه. هي حاله طبعا جميله، بس انت قلت ان انت لو كان at that time 2016 you don't have IVUS in your CAS lab. Yes. I think if this case will be repeated now, the strategy may be changed if you will. Especially,
I was very happy with these results. Even today, if I use IVUS, I will also prefer to finish like this. This patient.
أنا بس عندي two comments صغيرين قوي. هو أنا شايف الأوستر بتاع الCX could be significant, could be. الحاجة الثانية طبعا إن إحنا لو عملنا cross over stent من الليفت مين للLED, I think we can برضه حاجة simple ما فيش أي حاجة. كنا نعمل بوت بس في الليفت مين، الجزء بتاع البروكسيمال part of the stent in the left main, we may end by pot. لكن الحقيقه في النهايه final results is excellent.
احنا عملنا بوست دايليتيشن، عملنا بوت بس ما عملناش كيسنج. دكتور محمد وانا العيان ده بقاله 4 years he was clinically very good follow up حقيقه، وانا very happy with these results.
تمام يا باشا.
But I have short comments. Is this complex anatomy actually? This is a trifurcation lesion. And I noticed that ostial LED is healthy and ostial circumflex before deployment of the stent also healthy. So why Dr. Stehi chose the crossover from LED to left main while ostium of LED is healthy? Yani, this is number one. Number two, why you don't choose just to make stenting from the ramus direct to the left main with larger balloon to the distal left main only? And if I choosing, we have new stent now called BioSlim stent, which had 2 different sizes. The distal part is smaller and proximal part is wider. It is appropriate for such anatomy, which is trifurcation lesion. Number 3, I think we should end any trifurcation lesion either with triple balloon inflation or with sequential double balloon inflation, kissing balloon inflation. And number 1 in LED to ramus, number 2 from ramus to circumflex. This is just my comment.
I start from the last question. There is no guarantee in the guidelines for provisional stenting to end with the kissing. If you have a Timothy flow, you have no pinching. You can don't do kissing balloon at the end. Number one. This is number two. If you look for this picture, you can see that black in the distal left main. It is impossible to put a stent and to avoid any branch. You have to choose which branch you go to with a stent from the left main to the ElNady or the ramus. Which is more important for me? The ElNady is very important, the prognostic vessel. So the main stent should be in from the left main to the ElNady. And at this point, if you look to the ramus, it is a right angle originated from the left main. If you look to the angle from the left main to the ElNady to the ramus, almost more than 70 degrees right angle. So the possibility of closure of the ramus will be very low. Also for the circumflex, the angle is very large. So the possibility of black shift. And also if we look, the black is not at the trifurcation, it's mainly before the trifurcation. So the incidence of black shift is very low. So the strategy is that the possibility of closure of the side branches is very low. So I prefer to keep the stent from the left main to the most important vessel. The second point, I put 4 millimeter below because I have a stent reach to the proximal part of the ElNady, and I put the other stent overlapped with the stent in the proximal ElNady to the left main. So I was protected to use a large side stent, which is a 4 millimeter stent. If you put the stent from the left main to the ramus, the size of the ElNady is much bigger than the size of the ramus. So you need a large stent to be accommodated with the left main. So at least 3.5 to go up to 4 or 4.5. 3 millimeter stent to never go to 4 millimeter with the stent. You have to use at least 3.5 or 4 millimeter to adapt to the left main. So I prefer to choose the proximal part of the ElNady to be with the left main, not with the ramus. This is my answer. And Dr. Ahmed, this case was done in 2016. There was no smart stent or the.
Because there is a stent now called BioSlim, had different sizes in the proximal part and distal part.
I used it 1 or 2 times only. This stent because it's a limited length of this stent. It keep you limited in selection of the stent of the size of the lens.
شكرا يا دكتور محمد. احنا دلوقتي عندنا حالتين، في الدكتور احمد يحيى من عين شمس، وفي الدكتور محمد عز رجال من عندك برضو من طنطا، من الشباب اللي عندك. فاحنا دكتور احمد
محمد في ده عضو في اليوم بتاعي، خد بالك محمد ده يعني اندر ماي سوبرفيجن.
هذا الشبل يا باشا، هذا الشبل من زكي الاسد.
ربنا يخليك.
هم اللي كله بيجوا من طنطا بيقولوا احنا بنشتغل مع الدكتور محمد سطيح.
يا باشا ده احنا اخوات كلنا.
انا لسه حالا دلوقتي واحد لسه كاتبها حتى استاذ وانا معاكم في امريكا، واحد صديقي جدا بيكلمني بيقول لي انا في انترفيو اعمله لواحد مصري، والمصري بقول له بتشتغل مع مين، فقال له ان هو او يعرفني، يعني هو واحد من جامعه ثانيه الحقيقه، من احدى نطق من معهد قلب، فعاوز يكلمك. فانا انبسطت جدا ان هو يعني ايه ان احنا متواصلين، هو بيشوفنا يعني ان احنا انا وانت وكلنا بنشجع الشباب، فهو المقابله بيكلمني، فطبعا شرف